Welcome to the NIH Adherence Network Distinguished Speaker Series. My name is Susan Czachowski. I'm Chief of the Health Behaviors Research Branch at the National Cancer Institute. The NIH Adherence Network Speaker Series provides an opportunity for us to hear from major researchers and practitioners in the area of adherence, usually in webinar format, but today I'm delighted actually to welcome Dr. Victor Montori here. He is an international thought leader in the area of evidence-based medicine and person-centered care. He's in town for other meetings. He agreed to come to the campus in person to deliver this lecture, and we are most grateful. This is also, of course, being live cast, and it will be available as a webinar in our series. Just a note to those joining us online. If you have questions at the end of Dr. Montori's lecture, you will need to sign on to Twitter. We're receiving questions via Twitter today. Use the hashtag OBSSR adherence. And you will be able to type in your question, and we will have Dr. Montori address it. So Dr. Montori is a professor of medicine at Mayo Clinic in Rochester, Minnesota. He's an endocrinologist and a health services researcher who works to advance person-centered care for patients with diabetes and other chronic conditions. He's, as I said, internationally known for his work. He's authored more than 500 peer-reviewed publications, edited 2 books, and he was recently named among the top 1% of researchers with the most cited papers in clinical medicine worldwide in the last decade. So he's extremely accomplished, a member of the National Advisory Council for AHRQ, the Editorial Advisory Board for British Medical Journal, and many other accomplishments. As part of his work at the forefront of evidence-based medicine and shared decision-making, he's developed an innovative concept called minimally disruptive medicine, and he'll be speaking about this today. Essentially, it recognizes that adherence to medical interventions is work. It requires patient work which is often burdensome and very difficult for patients to enact. And so we should not be surprised, I think Dr. Montori is saying, when we have difficulties with patient adherence. This is quite normative. Minimally disruptive medicine seeks to take a truly person-centered view of medical care, and therefore I believe it's potentially transformative in that it asks us to reframe our approach to patient care with a real potential for improving patient adherence and ultimately health outcomes. So I am delighted, and please join me to welcome Dr. Victor Montori for his talk about minimally disruptive medicine. Dr. Montori.
Thank you very much, Susan. It's an honor to be here at NIH and also to be able to speak to you and to the people at home. We were joking before I started that it's common advice to a speaker to imagine the audience naked, and then it seems to me that in this day and age you have to imagine the audience in the webinar on their lingerie, reviewing the material. So I will do that as we start the conversation today. And let's imagine that this conversation is a bit of a walk in the woods where we're not really sure where we're going, and we're just noticing things as we go and taking it all in and critically thinking about these issues and then reviewing how those relate to our experiences, our lived experiences with the challenge of patient care and patient treatment adherence. In this first slide is my email address, and I'm hoping that people that don't get to participate in the dialogue can continue the dialogue through that venue. And those who are active on Twitter can use my Twitter handle, vmontori, to also continue the conversation there throughout this and obviously after the webinar. I do not have any financial relations that will affect the content of this presentation, or any other for that matter, as our research unit, since it started over 10 years ago, had a policy of not taking on any for-profit funding of any sort. So all our funding is either foundations or government. We're going to be reframing, or try to reframe non-adherence as a problem of implementation, or adherence as a problem of implementation, and trying to recast some of the interventions that sometimes are helpful in this realm as interventions to try to reduce the burden of treatment and improve adherence through reducing the work of being a patient. And to make it easier to understand and follow, I'm going to highlight the challenge of multiple comorbidity, multiple chronic conditions, as I think patients with multiple chronic conditions are the canary in the coal mine, are the first ones to tell us the challenges that they face in dealing with adherence to treatment. And it is important to look at models of causation of disease like the one I'm displaying here to identify that the plight of these patients is not just about their daily lives with chronic disease, but it has a larger context. We live in a world of violence and environmental mismanagement and poverty, with increasing improvements in levels of poverty that are unequal. So there's increased wealth inequality and alienation. And this context creates an epidemic of chronic stress, much of it structural violence-related stress, loneliness, which is has a stronger relationship with bad outcomes than obesity, and obesity. Put together, these interact with people's age and sex and genes, and creates an epidemic of multimorbidity. Again, when we see patients showing up with diabetes or depression or back pain or these sort of things, we must see them as a result of this set of causal links. And if we look at this graph looks like the wave, and it is I like to see it as an example of how sometimes language betrays us, because we talk about the aging of the population, and we easily imagine more 90-year-old people. But there's another aging going on here, which is when you look at, for instance, the middle-aged population between 40 and 70, there has been an increase in the prevalence of chronic disease in that group. And such a multi-comorbidity, which now affects 1 in 4 Americans, used to be something that we would see over the age of 65. We now see it across all the age groups, even into childhood. And one of the striking features of this graph is that the average person is no longer a healthy person. The average person in that age group lives with one chronic condition. So when we open the door of the medical center and a person walks in, chances are that that person will have one or more chronic conditions, and we should be designing our care to meet the needs of those patients. We also notice that about, as I said, 1 in 4 people live with one or more chronic conditions, and that starts at that particular middle-age group. To illustrate the challenge of these patients, I'm going to present John. And John is a patient I've been presenting since 2009. And I presented him essentially worldwide. And I have to say that John is one of these characters that is universally accessible. People recognize John. And in more than one occasion when I presented John to patients, there'll be somebody in the audience, men or women, who would come up to me and say, "I am John," or "I am Joan." And then go on and to identify how this case highlights their situation. So it is a made-up case, but it is a common situation. And John is a person that lives with diabetes and has been taking 2 medicines for that. He also has hypertension, was on one drug, but he was not achieving his targets for blood pressure control. So a new drug was added to his program to try to achieve those targets, but now every time he stands up quickly, he gets dizzy. He also has high cholesterol, depression. He has a bad back. He has pain in his feet from his diabetes, from his neuropathy. He also is obese. His doctors told him that it's time to go to see an endocrinologist, to see a podiatrist for his feet, to see a dietitian. For that, he'll have to take some time off work and to get a ride and go to the medical center. And he'll be told to avoid the salt, avoid the fats, avoid the carbs. He'll be told to exercise more, even though he has a bad back and depression. He struggles with that. He'll be told to check his feet, but he has an enormous belly that makes it very hard for him to check his own feet. So he'll be in trouble with that. He'll be told to take his pills, but we know he takes them because while otherwise he's dizzy with the beta blocker. He'll be told to check his sugar, and he does, and he writes it down. And when he brings it to the doctor looks at the sugar numbers, but then does it very quickly because he can just look at a blood test at A1C and find that it's elevated, as it is the cholesterol value, as it is his weight. And that seems to be the focus of attention for his clinicians, not the two other issues that bother John, which are that he is in pain most of the time and he can't sleep. Now, the reason he can't sleep, or one of the reasons he can't sleep, is because he used to be one of 3 accountants, then 2, then 1. The deadline, as a result, is always now. He has to perform. He needs to take the work home, and he's looking at the numbers closely, and they're not adding up. And he's thinking this company is going under, and along with it, his job and his ability to face his own financial obligations, including his mortgage. And the mortgage is not the thing that bothers him or worries him the most about home. The thing that worries him the most about home is the fact that his older daughter has come back to live with him with 2 beautiful granddaughters. And the reason she moved in is because she was in an abusive relationship in which drugs and alcohol were involved. And as a result, they were in an unsafe situation, so they moved into their house. As John is looking at his correspondence, he finds a letter from his primary care doctor indicating that because he's not meeting all the targets for diabetes control and blood pressure control, and John, essentially he's non-compliant, John should find another primary care doctor. When we see a patient like this, we're told to look at the guidelines. And the guidelines for diabetes, when the A1C is elevated, tell us that we need to intensify the therapy, add more drugs, encourage the patient to do a more intensive self-monitoring, use insulin combinations if that is not effective, and then move the patient to intensive insulin therapy, which includes 4 injections a day and blood sugar checks before each of the meals, in addition to carbohydrate counting with each of the meals. That is what we would be required, what we'd be asking John to do. Now, why are guidelines so evil? Well, they're not, but they seem to be relatively blind to the context of each patient. So here's our work on looking at diabetes guidelines, and what we notice is that very few of them make concessions on their recommendations on the basis of comorbidities that the patients might have, for different recommendations for glucose monitoring, healthcare visits, and glucose targets. Which is crazy, given that this is what a patient, for instance, with type 2 diabetes looks like. You know, 18% may have depression, 23% may have pain, 61% may have hypertension. So the most common situation for patients with diabetes is that they will have comorbidities, but the guidelines seem to ignore it. This is the cumulative multimorbid case if we take that presentation and we start cutting it out in pieces. And we can see that maybe some conditions sort of go together with each other. You know, obesity, cholesterol, diabetes, hypertension, they probably have a similar path. But depression, pain, dizziness, can't sleep may require its own attention. Here's a model of how those interact with each other, and we need to understand this so that we know why comorbidities must be paid attention to. One is issues of baseline risk. If your baseline risk, for instance, if you have diabetes, your baseline risk for heart disease is X, but if you also have hypertension and dyslipidemia, it's much higher. Obviously, the higher the baseline risk, the more worthwhile it is to get treatment. Responsiveness is another thing that's interesting. If you have depression and diabetes, and you treat the diabetes alone without treating the depression, you're not going to be as successful than if you treat the depression and diabetes together. So there's a responsiveness interaction there that we must want to take into account. And then there's the vulnerability to side effects. So for instance, John has neuropathy, which makes him unaware of the position of his feet. He closes his eyes, he gets dizzy. He takes an antihypertensive that we know makes him dizzy when he stands up. And he takes an anticonvulsant to control the chronic pain from the legs that has as its main side effects dizziness. So the 3 of them together increase his vulnerability to dizziness and falls. So clearly we must consider what comorbidities the patients might have, particularly if we want to then go on and apply each of the available guidelines that a patient with multiple comorbidities might have. We will find that about 1 in 5 of these, if we apply all of them that are pertinent, you will find that 1 in 5 includes applying drugs that will produce serious drug-drug interactions. So if we define high-quality care as adherence to the guidelines and we apply it to the patient with multiple comorbidities, not only do we create an enormous amount of work, as we will see, but also it may actually not achieve the health goals that were considered by the guideline developers. That's comorbidities, but the guidelines are also blind to other aspects. They're blind to issues of personal or social personal situations. They're blind to also preferences. And you can see the proportion of the recommendations that show some degree of variability in relation or consideration to context and preferences, and it's very low. Now, let me pause at this point to point out that I don't pretend that guidelines should pay attention to all the possible permutations of comorbidities and all the possible permutations of patient preferences and personal situations. The problem is not that they have to account for all of that, is that the existence of that variation in comorbidities, preferences, and context makes it very hard for those guidelines to give definitive recommendations that we all must do or else be considered poor quality providers. And the situation right now is that strong recommendations of guidelines are converted into quality parameters that reduce our ability to specify what we would want for patients to do in respecting their preferences and context. And I think the same is true for quality measures that derive from these guidelines and for some of the specialist care, frankly, that as a result create care that is disease-specific and context-blind. When it all piles up on the individual patient with multiple chronic conditions, the regimens become increasingly complex. And if on top of that you have poor care coordination, which in other words means very little prioritization. And I don't know if you are familiar with primary care efforts to try to, like the medical home, for instance, that try to coordinate care. A lot of those efforts are focused on coordinating care in order to achieve the target metrics and the quality metrics. And so it is about deprioritizing things that will get in the way of achieving the quality metrics rather than prioritizing so that patients can fit this amount of work into their life and achieve their personal health goals. And there's an enormous shift to self-management, which is, as we will see, it's a shift of work from us to them. And there's, as a result, an increasing in the treatment burden that overwhelms the patients. So this is the work that John sees. And let's break it down. This is based on on work that Carl May, a sociologist from the UK, has done along with Francis Mayer, and in this case Katie Gallagher, looking at what is the work of being a chronic patient. And this is a simple structure to understand it. First, there has to be is the work of making sense of what is the work and what is the work asking of me. If patients skip this step, then nothing makes sense after that, and it's easy to discontinue or stop. So there's sense-making work. This is why patients open up drugs package inserts to read them, or they Google stuff up. They need to understand the work. Then there is the organizing that work and enrolling others. And as you can see in that photograph, she calls him Sunday afternoon and set up your pillbox. So he needs to stop whatever he's doing, watching the Vikings game or whatever, to come down and set up the pillbox. You can imagine those are moments of low tension, right? And so she sets up the pillbox with him for the week. Now, if you notice, she has a medical alert bracelet in her left wrist, which basically means she's also a patient. You can easily imagine what will happen if she were to fall sick. He'll begin to take the medicines right out of the little orange containers. And we know he's not going to be as good as when he and his wife set up the pillbox. So keeping her involved in his care is an essential component of him being able to get the work of being a patient done, particularly in relation to pill taking, as you can see here. So he needs to keep her in love, which is tough, right? So at least, she needs to feel, for him that she needs to help him, but he doesn't look that sick. He maybe look a little lazy or something. He doesn't look sick. And this is the challenge for chronic patients, is that it's very hard for them to elicit the kinds of sympathy and support that a patient that is acutely ill might easily create. Then, of course, there's the work of being a patient, taking the pills, go to the appointments, get the test, do the day-to-day things. And then the work of reflecting and monitoring and deciding, is this worth doing? Should I do it again tomorrow? And so if you're interested in supporting the work of adherence and supporting the work of being a patient, you've got to support each of these steps. Now, this is a personal picture. This is my wife's forehead. And we are on vacation. You can see the nifty, mirror here with the little conch shells. We're on the beach. But before we got there, one of my sons, not the one here, another one, became sick with C. diff and was given a prescription for vancomycin after failing metronidazole. And the prescription read 4 times a day, vancomycin, have a great vacation. right? And so you have a 10-year-old at the time or 11-year-old at the time going on vacation to the beach 4 times a day medication, right? It's really hard work. And how do you not turn into the prescription police, right? Going after the kid and making sure they're taking the medicine. So this is what my wife set up to, she looked things up, researched a bunch of things. At the time, she was excited about 5S methods of organizing, part of the lean approach, all these other things. And she came up with this method, very simple. They're at the base of the week, 4 times a day. And all he had to do was come in and pick up the next envelope. All we had to do was to look at the time of the day and see if the envelope had been picked up. And so at least we reduced the amount of running around. Did you take your pill? Did you take your pill? Did you take your pill? Type of action that would have driven us crazy and made the vacation a nightmare. Organizing this kind of work takes time and imagination and resources. And she looked things up online, and there's some literacy involved in all that work. And the execution was very good, and he managed to get all his pills on time. But I guarantee you, the pediatrician, when he was writing that prescription, had no idea that it will take this to get that done. Turns out there's very little information about the work of being a patient. It's incredibly little. There's actually one systematic review published in BMC Public Health in 2012 with very low quality evidence. And most of the evidence in diabetes, and most of them conclude it's about 2 hours a day with very little assessment of how much time it takes to be a patient, to be a good patient. Work discussions happen in the office visit quite a bit. At Mayo, we had this average 24-minute per visit, so long visits in primary care. A lot of workload discussions came up. We observed them through video recordings, but we also observed that 70% of them raised issues of work that was not getting done and was left unaddressed. In addition to the traditional work of being a patient, there's new work, because we're not satisfied with the usual work. We are now giving patients more work. And so this is a brief list of all the new work that we're asking patients to do. You must come prepared for the consultation. You must watch this new educational video we just put on YouTube. You need to bring questions. You need to be prepared for those and be ready for new ones when you're with us. You might want to record the visit, and maybe you review this after the visit so you will remember what we discussed. You may want to review your medical record. We have open notes. You can look at them anytime and work through them. We will not change our jargon when we dictate it, because those are records that are really for us, but you can review them anytime. You can communicate with us through the portal and transmit the data through that. You have to self-measure, you have to self-monitor, you have to self-manage. You have to manage your appointments, your prescription, your bills, your refills. By the way, you may want to keep some family and other important others informed of your health. And you also, you're a caregiver, right? And you have to take care of significant others. And don't forget to advocate for yourself and for others. Right? So this is non-traditional patient work that we are now pushing and creating on people, and under the guise of skin in the game, increasing patient responsibility, and so forth, on patients about whose work we know nothing. Well, all this work falls on these patients and their caregivers, their family members, their social networks that face the work with a given amount of capacity. So where does this capacity to do the work come from? Well, it comes from a sense of purpose and motivation. It comes from a sense of agency. I can do things. I am an author of my day-to-day life. I can make things happen. Many people lack the motivation, the sense of purpose, of joy and agency to actually make things happen, but that contributes to capacity. Resilience, being able to stand back up after being punched down and being ready for the next day in the battle, particularly for chronic disease, is a potent source of capacity. Obviously, literacy, not only to understand, but also to take exception. You see, when you're an expert, you know what shortcuts to take. When you have chronic disease and you're highly literate, you know that it's not that urgent to take the medicine at the exact same time. And yes, when they say empty stomach, it doesn't mean the other tablets. We had a patient show up at Mayo Clinic and being worked up for dementia because she couldn't get anything done during the day. So she was abandoning a lot of things because she became really focused on making sure that every pill that she had to take on an empty stomach was taken on an empty stomach, which had her take pills every 2 hours throughout the whole day. And she stopped eating, it was a disaster. So her daughter had her worked up for dementia before a pharmacist helped her out. This is an issue of bandwidth, which is very interesting. You may be very familiar with this concept, but it was new to me. And it's the idea that somebody who is cognitively very bright can be made quite dumb by worry. So just that you can get worried sick, you can get worried dumb. And this is apparently highly reproducible. If you're asked to do some math, and then say you're poor, and somebody says, please come up with $3,000 by Friday, and while you're struggling to figure out how you're going to do that, you're asked the same math, you underperform dramatically. So people who are always concerned about what am I going to eat this week, where am I going to sleep this week, can I get some help this week, may actually make dumb decisions about their own care. And so that will be not because they're dumb, but because they have a reduced bandwidth because of worry. Health issues, obviously, if you have mental health issues, or if you have physical health issues, particularly if you have under-rehabilitated limitations, if you don't have your cataracts fixed, if you don't have adequate glasses, if you don't have hearing aids and you need them, if you don't have ambulation devices, canes or walkers or things, you will walk very slowly and in pain. That means that if something requires you to move from point A to point B to get something done, that's all you'll do in the day because it will take you a while to get there. Financial health, of course, the phrase, it takes too much time to be poor is one of those things. Money can buy you love, but it certainly can buy you help and time. And so if you don't have the money to get you help and time, then you have to do everything yourself. And so it just takes longer, and so you do fewer things. You have less capacity. Social skills and social capital, social network size, these are all very important features in a world, as I've mentioned at the top, where loneliness is a significant problem. We sometimes, in our clinic, when we invite people to get their colonoscopy, we alert them that after the colonoscopy, they may be somewhat groggy from the anesthesia, and then we say, bring somebody to take you home. And you see in the faces of a few of these patients that they don't have anyone to ask. They just can't get anyone to come and pick them up from the hospital. Or if you ask a patient that's in the emergency room, you need to come in, and they're thinking of their dog and their plant, and they have no one to ask to come in and take care of the dog or take care of the plant. That's severe loneliness. If they can't get the help to do that, they might sometimes say, I don't want to go to the hospital just to take care of the dog and the plant. And so they can't really do the work of being a patient because they're too lonely. They don't have enough social support. And then, of course, environmental, if you live too far away where nothing can get delivered, the internet has not arrived, or if you live in an environment that is too violent, too noisy at night, where you can't sleep and you cannot go out for a walk. These are situations that reduce your capacity to take care of the work of being a patient. This model that we developed, led by Nate Shippey, is the cumulative complexity model, and talks about this balance of workload and capacity, and how if we have a balance of workload and capacity, then the patients can access care, use care, and enact self-care, and if that care is effective, they can have better outcomes. We understand that what I put up at the front of all this burden of treatment that is context blind and might produce this enormous burden of treatment that increases the workload. We know that live also adds to the same work the same capacity has to deal with both the work of being a patient and the work of life. I'm a diabetes doctor, and so oftentimes I see patients doing very well, and all of a sudden they deteriorate. And when it's very common that when I ask what happened, it will be something related to life. They got a promotion and the work is now heavier. Or they became a caregiver. Now my daughter is sick and I need to take care of my daughter. And these kinds of things are meaningful to people. The work of being a patient, not meaningful. The work of caring for others, the work of your job that helps you provide to your family, meaningful. I ask these kids what they want to do when they grow up, and they come with a list. And this list of things, they never say, I want to be a great patient. It's not a meaningful target, right? It's not something. So every time life shows up with a meaningful request, patients are happy to flip their capacity to address the issues of life rather than continue to work. And so if the capacity is limited, some of the work of being a patient will not get done. Any general form of scarcity is going to contribute to reduced capacity. So in addition to the issues of cumulative complexity, there's going to be some cumulative disadvantage going on here, as we see that patients with low capacity will have worse outcomes. If people are showing up to the doctor with, say, a high A1C, as John, and the response is to increase treatment, increase the burden of treatment, this imbalance is going to get worse. And if the patient, if that's what the doctors are seeing, the A1C, not the depression, not the anxiety, the burden of illness will continue. And so the capacity will go down. So we have a vicious cycle of increased health care that is not enacted and worsen outcomes that is driving the patients to have a worsened imbalance. And you can see the picture of that imbalance in this photograph of Maria Luisa, a Peruvian who lives, I'm from Peru as well, she lives in Alaska with her son and her son's family. And she's been labeled non-compliant. She lives with chronic conditions, she's on dialysis 3 times a week, but you can see it in her face. I don't have to tell you that story. She's looking at all those pills, and you know there's trouble. And I think that one of the problems with non-compliance is that, for at least in the clinical world, is a non-starter. If I get a phone call, say, I have a 35-year-old man that's non-compliant, that's it. I know that that's going to be a losing proposition. Once somebody's labeled as non-compliant, they're a bad person. You will not want to invite them to your birthday party. So we need to try something different. And I think if we were to say, no, Maria Luisa has a problem, an imbalance of workload and capacity, and if we work with it as a syndrome, we might actually have something more we can do with it. So is this imbalance because of life or because of too much patient work? Is it acute or chronic, or acute and chronic, as is almost always the case? Was this caused by life work or patient work? And is this caused by personal reductions in capacity or maybe socioeconomic reductions in capacity? So we have a differential diagnosis. We can work it as a clinical problem. And it gives us an opportunity to go beyond the label. So if you think about John, does John have a workload to capacity imbalance? You bet. Is it acute or chronic? It's probably, there's some chronic elements here and there's some acute elements here that are working together. Is it an increased workload? Well, there are intensifications of treatment going on from a patient work perspective, but certainly becoming the only accountant increases life work. Plus the work of working with his daughter and granddaughters at home. Is it reduced capacity? He can't sleep. He's in pain. He has reduced capacity, but he's also worried. He's worried sick, so he may have also reduced bandwidth. So he has probably a workload capacity imbalance due to both increased workload and reduced capacity. We now have some evidence that's beginning to accumulate that begins to put numbers into how often this is happening. This was published in July this year. National sample, representative samples, 65 and over Americans, 2,000 responders, and you can see 40% of them are endorsed one of these statements. You know, clinicians are asking too much, the work is too hard, and the work is either getting delayed or not getting done. And the most common situation for this is patients with low socioeconomic status, reduced material capacity, so to speak, sicker patients, and those who were more likely to delegate the work to others because they couldn't handle it. With very little data on this, but it's beginning to come out now. So what might we do? So if the patient has increased workload, it could be from life, it could be from the treatment burden, we may need to do that work. If they have decreased capacity, we may want to think about how is it that the ability of the patient to do the work, their functional performance, interacts with social capital, in other words, their ability to identify and get resources to support that work, and social skills, the ability to enroll others and help them with a task, like that man with his wife, in order to be able to do the work. How their ability to have this social capital, social skills, how their ability to actually be able to do this work prepares them for adversity and allows them to survive it, and how that resilience furthers their sense of agency and keeps them going for the next round. So this is Carl's extension into what he's called the rethinking the patient, the treatment burden theory, and how capacity is, in fact, cannot be understood as the capacity of one person, but the ability of that person to get resources and help to face this. And as their functional performance declines, for instance, as they're getting older, they become much more reliant on the social skills and social capital, in other words, the work of others. And if they have difficulty accessing health care, they'll have less health. And so now that connects with the bigger picture of again, not only cumulative complexity, but also cumulative disadvantage. So the way to think about this imbalance is that it's not only faced by the patients, but it's faced by the patients and their social networks. Only very lonely patients face this as individuals. I'm not a theorist, and this is from sociology. And as you know, sociologists are like the mafia. The mafia makes you an offer you can't refuse. Sociologists make you an offer you can't understand, right? So it's a bit of a challenge, right? But if we think of the work of implementation, the work of adherence as work of implementation of a treatment program in people's routines, then it's important to use a theory of implementation to understand where that fits. So this is a general theory of implementation, again, Carl put forward a couple of years ago, in which there are some resources that allow you to, that need to be mobilized, that allow you to implement. That's where capacity sits. In fact, he used two words. For the social cognitive, he used potential, and for the social structural, he used capacity. For simplicity, I'm just calling it capacity. The potential component of his theory captures most of the cognitive, social cognitive, and social behavioral theories that have really dominated the field of adherence, at least in what I can see. But those just refer to the resources that need to be mobilized. An important component is this idea of capability. And capability is a characteristic of the way what is being implemented interacts with the implementer. So it's not a fixed feature of the intervention. It's a feature, as a dynamic feature of the intervention as it interacts with the implementer. And so he talks about workability. In other words, can I make it work? And integration, can I make it become part of the routine that I have? So, for instance, a very organized traveling salesman is probably quite able to make it work, but is challenged in the integration by the change in routines and time zones affected by the traveling. So that patient on the picture who relies on his caregiver for this work, relies on the caregiver for both workability and integration. The caregiver has to understand the pills and how they fit into the pill box and has to bring the patient into the Sunday afternoon sit-down to make it work on a day-to-day basis. So the capability of the intervention, taking pills, going to appointments, etc., it's not a fixed feature of it, but its features affect how it interacts with the user and with the user's context. And then, of course, the work or contribution in this, which is a term that he uses in this theory. The contribution is what we've now learned, is making sense of things, planning and enrolling others, doing the work, and then reviewing an appraisal. So that is where he draws from the theory of normalization process to bring the work to that point. So the general theory of implementation understands there are resources that are mobilized, potential and capacity. There are interactions with what is being implemented, which relate to the characteristics, workability, and integration of the intervention that interact with the context and characteristics of the individual or the people that are implementing, and then the contribution or the work that is what makes it happen on a day-to-day basis. This happen to be targets for intervention if you want to improve adherence. You can try to improve potential, and that's your motivational interviewing, or a big part of a behavioral modification is trying to increase the potential, a sense of agency and motivation. Maybe it's capacity when you're trying to bring resources, for instance, lowering the cost of interventions. Capability has to do with moving into a once-a-day regimen or a once-a-month injectable or something along those lines, simplification of the treatment program so that it is not so hard, for instance, with someone's busy schedule. And then the work is when you educate patients to help them make sense, or when you give them some way of monitoring whether the efficacy of the intervention is working, for instance, to support the review component. So how might we reduce the treatment burden? Well, maybe this is for everyone. We may need to prioritize, so the accumulation that may have happened to this point gets simplified. We may need to deprescribe to some extent if we need to reduce it. As you will see, there might be strategies to improve capacity that require us to actually intervene, actually prescribe new stuff that might reduce symptoms, reduce pain, improve sleep. So it's not always deprescribed, but often it is. Then we need to simplify the access, in this case, to medications by looking at generics and low cost, looking at systems that facilitate the refill, which is a double-edged sword for us, because if we use refills data to monitor adherence to therapy and we facilitate the refills, we will lose our monitoring strategy. So this is a bit of a challenge. Some delivery systems, mail order pharmacies are potentially very helpful, but sometimes it's helpful to have the patient come in and then have the medication, so the medical care and the medication refill all delivered at the same time. I don't know that those have been compared face-to-face, but head-to-head, but it's interesting. And then simplify the use, simplify the administration. I think in HIV we've seen an enormous progress in the simplification of the administration frequency. Bundle the prescriptions. There are now ways of putting them into single packets and then use a pill box. This is very simple. I just focus on prescriptions for this. But you can go through a similar arrangement to think about how do you reduce the work of, for instance, getting another appointment or paying your bills. One of the ways of prioritizing is by involving the patient in choosing to what extent, or in identifying to what extent the interventions that are available to them meet their needs and are consistent with their values and preferences. So shared decision making is one opportunity. We developed about 10 years ago a program to help people decide if they want to be on a statin, medication that has historically had about a 50% adherence rate, even if it's primary prevention or secondary prevention of people with diabetes at 2 years or more. The challenge here is statins do most of their work of prevention after you take them for 2 years or more. So most people are taking them within the time frame where still you can't see the separation of the curves and then they're quitting. So improving adherence becomes important for statins. So we have a calculator, and so in this calculator, for instance, here's a 55-year-old man with no cardiovascular risk factors, and we use these pictographs depicting 100 people like him, and the way we would use it is, Mr. Jones, you're in a room with 100 people just like you. 92 in green here will not have a heart attack in the next 10 years. 8 in orange here will have a heart attack in the next 10 years, and I do not know if you're one of the green ones or one of the orange ones. Now, if all 100 were to take a statin, we put them in the room, we close the door, we open the door 10 years later and we count, we'll see that the 92 people that were not destined to have a heart attack will have taken medicine with no benefit. There will be 6 people here in orange that would have taken the medicine also with no benefit. They'll still get the heart attack despite taking the medicine regularly. And then there will be 2 people here in blue that would avoid the heart attack by taking the medicine regularly. I do not know if you're one of the green ones, one of the orange ones, or one of the blue ones. Now, Mr. Jones, are you interested in taking a statin? Now, what's remarkable about this, as you're thinking, reflecting if I was Mr. Jones, would I take a statin or not, is that this is 8% risk. That's more than 7.5% risk, which is the current guideline level above which you must prescribe a statin. So if your sense was like, there's no way I'm going to take a statin with that graph, and you go to see your doctor, and that's your situation. Your doctor will be telling you, you got to take a statin. Your doctor trying to be evidence-based, adherent to the guideline. And if your doctor is showing you this tool, he's also trying to be patient-centered. But that may result in non-adherence to the guideline, create an interesting conflict that should probably not exist. That was a risk-based model. Here's a different model. So say you also have diabetes, and you now need a new diabetes medicine because your sugars are too high. So most clinicians might just say, here's the next one, here, off you go. But there's another way, because most diabetes medicines are different only in aspects that matter to patients. There are no major differences in outcomes that we know of or that we're comfortable with. So the way that this will work is, what aspect of your next diabetes medicine would you like to discuss next? And the patient might say, patient with type 2 diabetes, usually overweight, usually we've been telling them again and again and again they must lose weight, so they go for the weight change. And they look at that card, these are physical cards that they hold, and they'll see that, there's 2 medicines here that might help me lose weight. I'm interested in those. Say, okay, what aspect of those medicines are you interested in? Well, how do you take them? Well, this one is an injectable medicine. Before this one in the bottom existed, this was the only one that was associated with weight loss, and it was an injectable. And for the first time in my life as a diabetes doctor, I heard people saying, I can lose weight, inject my eyeballs, which was an unusual thing. But then this pill became available. So, you can lose weight with the pill. Okay, I'm interested in that one. Okay, what aspect do you like to learn next? Well, how much does it cost? And it's, that's $8 a day, and you're used to metformin, which is 10 cents a day. Is that 80 times more efficacious, doctor? No, it's just they got 80 times greedier, that's all. Oh, So if they're cost sensitive, you might see their eyes going, well, what about that inject my eyeballs one? Oh, that's $11 a day. Oh, that's too expensive too. Or weight neutral is the next one here, 1 pill a day, $7. Geez, well, maybe I can't afford weight loss or weight neutral. How about these little weight gain, 1 tablet a day, 10 cents a day? That's my drug. And you'll see patients do this with their eyes until they find the right one for them. And 2 or 3 cards is usually all you need. That's about 3 minutes or so to the consultation. We've done this for depression. We just published this in JAMA Internal Medicine about a month ago, helping patients in primary care work with their clinicians to identify the right antidepressant for them. We were told when we started this program that only young people will actually go for this, and nope, you can see the range of ages. We were told, well, just a specialist. Nope, we've done it in the emergency room in primary care. We were told that clinicians will be a barrier. Nope, not if you design the tools with them for their workflow. We were told it takes too much time. Yeah, it does take time, like all good things in life, but not a whole lot. That it needs a lot of training. Not really. Fidelity is not great at 58%, but it's not bad either without training. We were told that this will only be for the elite that has clinicians that have time to talk to them. But we noticed that the effects are bigger in vulnerable population. And we have not been able to show or demonstrate improvements in adherence or other clinical outcomes or cost, in part because of the same problem that we see in most clinical trials related to interventions to improve adherence, is that you can't find low-capacity people showing up to your consultations frequently enough to enroll them. So one of the challenges in most of the literature for clinical trials is how do you find and enroll and keep enrolled non-adherent people? Because those are the ones that are susceptible to the benefits of intervention. So we will do the observational studies, find that, for instance, for statins, 50% of people will take the medicine at 2 years, and then when we enroll them, the control group has 100% adherence. You can't improve on that. In fact, you probably have lower, we have done in a couple of our trials, we have lower adherence in the intervention arm because we have like 97%. You just can't get it. Then the last objection we got is nobody will use them, and so we are hitting about 10,000 users a month, 4 minutes per use on average on our website. And you can see the distribution around the world and the distribution in the United States. Minnesota is the darkest one, but it's not Mayo Clinic, actually. No one is a prophet in their own land. So it's Essential Health in Duluth that is the biggest user. So in addition to prioritization and deprescribing and simplification that might reduce treatment burden, there might be opportunities in coaching that can help us identify problems in capacity and enhance those problems. For that, we've designed this tool. Casey Bamer from our team is leading this work, in which we are, this is a tool that patients fill up in the waiting area. It takes about a couple of minutes to complete. And patients mark in the first column here whether these areas are a source of satisfaction or a source of burden in their lives, or both. And then they write here the things that we are asking them to do, and they mark if they're a help, a burden, or both. And then they bring this into the consultation, and the clinician opens up with an open-ended question. Now, when we've observed this, the open-ended question that clinicians like to use is, what can I do for you today? Which turns out is not open-ended enough. What can I do for you today is limited to the things that patient thinks the clinician can do, which is a shrinking amount of things, right? It's not. So we've been rehearsing new open-ended questions. There are 3 that have increasing levels of risk. You'll understand what I mean by risk when you hear the questions. The lowest risk one is, what's on your mind today? Interestingly enough, almost invariably, what's on your mind today elicits urgencies that have nothing to do with healthcare. I'm thinking I'm not going to make it to pick up my daughter from school if this appointment keeps going long and you start asking open-ended questions. So there's stuff like that, right? It's worries, concerns that are usually not healthcare related, but give you a sense of what their life is about. Very helpful. And the second open-ended question you can ask is, what would you be doing if you were not here with me today? Trying to get at, I will be doing woodwork in my house, or I'll be in the middle of a discussion at work, or I'll be, give you, again, a sense of what life is about, because you need to understand that, because that's going to interact with your intervention, right? So that capability assessment is what you're really doing at that point. The last one is more of a capacity question, and that is, what gives you joy in your life? That's a highest risk question. It's highest risk because you may, and we have seen this happen, you may find people that will tell you nothing. I have no source of joy in my life. Right? And that's a tough situation. But if you are dealing with a car that has no gas, you wouldn't try to jumpstart the battery. So the notion of patient activation and motivation, all that stuff, it's a bit sort of empty if the patient has nothing to live for, if there's nothing that gives them purpose and joy. And so it is often the case at that point, as it is with many of this stuff afterwards, that your job as a clinician is to say, all right, we're dealing with that. We're going to work through that together. And what you're doing is creating or enabling a partnership in which you recognize that that's going to be a core component of that work. For chronic disease, ongoing relationship, understanding what you're up against becomes absolutely essential. And the fact that you're stating that you're going to partner with the patient to address that will be very important. Then you say, okay, so you clicked a bunch of places here. What jumps at you? Because it's not like you're going to go, all right, let's talk about your family and friends. You mark here it's a source of burden and satisfaction. Would you like to tell me more about your family and friends? Okay, let's go into your work and what's the source of... You're never going to get done, right? So the idea is, okay, what jumps at you? And the reason you do that is because the patients, in completing this, have had a chance to reflect on this. And something has jumped at them. And so you're just trying to start there. And what we see is, in fact, it is a very helpful tool. You know that there's a problem, and this elicits it. You know this is a can of worms for clinician, and you're opening that can in a way that is organized and helps you have the worms come out in single file. You can address them. And the other thing is that there's a geographic distribution of this. These are the kinds of things that clinicians are used to potentially handling from a palliative care perspective. But this is the stuff that maybe they will delegate to a care manager or a health coach, a wellness coach. If this is being managed in a consultation with a wellness coach, that's the stuff that the wellness coach is more familiar with, and they will refer to the clinician for this. So it begins to make a connection between what needs to happen in the community or community resources and what needs to happen in the healthcare arena. And of course, this is the part where if it's something that you're expecting the patient to do doesn't show up listing, it's probably not happening. But also you can identify a bunch of things that the patient is either perceiving not of help. In other words, it's failing that review component of the work cycle, or if they're perceiving it mostly as a burden. That means that they are at high risk of getting dumped. That's going to stop. And so you can use that list to maybe streamline some of the care and reduce the burden of treatment. We're in the process of evaluating that tool, so I can't tell you how well it works because we're just trying to get the grants and doing the preliminary work for it. It connects quite nicely with programs like Kate Lowry self-management training. It calls very nicely for involving our colleagues in palliative care, not for people who are dying, but for people who are living with chronic disease. Obviously, it has a nice place for mental health. It's a nice place for physical therapy and occupational therapy because you're going to bring function back to increase capacity. Here's Maria Luisa again. When her son went to work in the morning, if she was in the top floor, that's where she stayed for the day. If she was in the bottom floor, that's where she stayed for the day. Putting this stuff, which required mobilizing some financial resources and community agencies, allowed her to now have ability to do more, get more done in the day, which is important to achieve her goals. We've also tested this model in looking at readmissions. You see, we put people in the hospital, they're sick, we give them a bunch of new work, and we ship them out still sick, but new work. So clearly it's a situation of acute, if not chronic, acute capacity workload imbalance. And so we looked at 25 years and 45 randomized trials where we took the interventions and gave them to people that were blind to what the outcomes were of the trial and said, do you think this intervention reduces treatment workload or improves capacity or both? And to what extent? And then we used that as an explanatory variable, and we found that interventions that address the issue of capacity were 30 times more effective than other interventions, suggesting that if you were to have that, you may have a better outcome in terms of 30-day readmission. What was also fascinating about this is the majority of interventions that were effective at capacity were human-intensive interventions. Nurses went to people's homes. There was a very warm hand-up. It was not technology-driven. It was high touch, not high-tech. Now, that's clinical, but these patients get care in an environment, in a system of care. And the system of care, the front lines of our pharmacies and clinics and hospitals, may be hostile to them, and they introduce additional work of being a patient. So here, these patients are being asked to wait in line, and they got tired, so they put their shoes instead of standing themselves in line. I don't know where this picture came from, but it's just a wonderful depiction of this. And we know how we sometimes organize care, and we justify it on the basis of our own limited resources. Rehabilitation center, open from 12 to 2 o'clock. All right, so if you're bringing a full-time job, you're just not going to have 10 sessions, right? That's not going to help. That's not going to work for you, right? If you miss 3, you cannot come back again. This is a rehabilitation center in Spain. When I was giving this talk, somebody gave me the example. They open up for 2 hours during the day, during work hours, because that's when the therapists are being paid for. And if you don't make it, you get kicked out of the program. So very unforgiving. So we need to think about how when we organize our service. At Mayo Clinic, if you call the pharmacy within 10 days of the prescription running out, you get your prescription refill sent home. But that's the stress test of a patient-centered organization in relation to this, is how sensitive they are when you call in 11th day, right? Because they have a chance, right? They can demonstrate to you how patients... So if you call the 11th day, or if you go online on the 11th day, what you get is a message that says, no, you are not within 10 days of your prescription. Call again tomorrow. Goodbye. Right? Versus, we will process it. We will save your information and process it when the day 10 comes in. Why not? Right? What? I'm sure there's a reason, right? But I'm sure it's a ridiculous one. You know that person had a divine inspiration to remember today to renew their prescription. Tomorrow is another day. Right? They managed to make it work today. Why can't we just kind of honor that and be respectful of that work? And then when it comes to capacity, we have a big problem of this idea of the social support of the treatment burden. How might we mobilize communities that may be already organized or that should be organized around the needs of these patients? It's part of our obligation. We cannot do this alone in healthcare if we don't have sufficient social capacity to overcome the problems of treatment burden. So that's another, I think, missed opportunity. Here's Maria Luisa. Her family is very supportive. They changed her dialysis to the afternoons. That gave her 3 days in the mornings where she could get stuff done. She was living a part-time life. She would go in the morning, get dialysis, and then go to bed. 3 times a week, she was gone, done for the count. But by doing it in the afternoon, she had mornings that became available. Then by chance, when she went in the mornings, there were 2 nurses that spoke Spanish. So her life, her world just expanded beyond her family. So that made her a little happier. That proved to be very helpful to her. The mornings now she used those to do her crochet. She started doing crochet for her granddaughters. Now she had a bit more purpose in her life. I'm going to stop by pointing out what might we do with accountability, because I recognize that some of the pressure that we have for some of our work comes from the quality measures. And I've shown this to clinicians, and they'll be very happy to be held accountable to, are we overwhelming people? How easy it is to use our resources and access our care, and are we moving not only disease control needles, but also function needles, and also physical and mental health needles. And that has some endorsement. The problem is application. It's a significant area for further development. Ultimately, we want to be held accountable to her. We want to be able to make sure that our care is the best for her, the best for her family. This is she turning 88 earlier this month, so that we make sure that we advance her healthcare goals. Thank you very much for your attention.
Pressure to decrease patient-doctor visit times, what's the best strategy to scale these recommendations?
The question relates to the time that doctors and patients have together, and is getting smaller. That is not by divine act, is not a natural law. This is a design, somebody's idea of what healthcare should be. And I think it is time for us to point out that there are consequences to that design decision. One of those consequences is the inability of patients and clinicians to have discussions about, for instance, workload and capacity. That leads to non-compliant or non-adherence or workload capacity imbalance situations that bring the patient back sicker the next time around back to the queue. So you end up having a revolving door problem that creates a sense of, oh, I have limited access in a big queue. When in fact, if you just slow down, give yourself a little more time, you may be able to address the situation of the patient correctly the first time. That's a measure of quality. So I think that the answer to the issue is not to live with the fact that the appointments are getting shorter, but is to reject the notion that appointments must get shorter and actively advocate for longer, more effective appointment times.
Thank you.
Other online?
We also have a question from Teresa Heyer. How would you apply your research to veterans with multiple comorbid conditions?
I do not know that there is a reason for that to be any different from what I've talked about today. In fact, there is an innovation program going on in Wisconsin, in one of the VAs in Wisconsin, that is focused on implementing minimally disruptive medicine in the care of veterans. I do not know, it's in the preliminary stages, so I don't have any outcomes to report, but I can say that I don't think there's going to be a particular challenge, given that I know that they've been one of the early adopters of this idea.
I think we're just about at the end of our time. Thank you so much, Dr. Martori.
Thank you.
Fabulous talk, very thought-provoking, and a lot to think about. Thank you so much.
Thank you, Susan. Thank you.